All right, so we're doing chronic renal. So chronic renal are things that we've ended up with in terms of like diabetes and hypertension, ASCVD. All those things have led to this point. So it's an appropriate ending point as well for our lecture series. So we'll talk about the chronic reasons why you get renal disease. There are acute reasons, and acute reasons you'll talk about in Med-Surg 3, right? That's where you talk more about acute things, and you have to think about all the different reasons why someone comes to the hospital with an acute injury to their kidneys. This is chronic injury to your kidneys. And ironically, when you leave the hospital with acute kidney injury, you can end up with chronic kidney disease. Just like when you go to the hospital with an MI, you can end up with CHF, right? So you can fast track it. All right, so we're talking about chronic renal disease, CKD. So the color of choice today was dark yellow, meaning that we need to hydrate more. All right, so chronic kidney disease. So it's progressive and it's irreversible, just like what other disease processes? CHF is irreversible. What else? COPD is irreversible. Alzheimer's is irreversible. So this is another irreversible disease. All right. It is a little bit there's a little caveat, there, a little asterisk. It's after stage 3. There are 5 stages of chronic kidney disease. 1, 2, 3, 4, and 5. None of those are acute kidney injury. That's a whole nother ball of wax. So we're just talking about chronic kidney disease, and you can develop it over time. You can have stage 1 because your diabetes is out of control. You can have stage 2 because your hypertension is out of control. It can keep escalating. And so that's why you manage your hypertension and you manage your diabetes, you manage your ASCVD, you manage all these other things that might insult your kidneys, right? So we have 5 stages of kidney disease. And that could be, and then again, at stage 3, that's really where it's irreversible, where the kidneys are so inflamed, not really inflamed, but they're so broken down because of inflammation, because of damage over time, that they're letting everything through, right? Normally, your glomerulus filters things, right? Normally, it's a colander, or here is a French press if you're fancy, right? Everything goes through it, right? And then it's your job, your nephron, to reabsorb things you didn't want to get lost, such as glucose, right? Remember, you have glucose transporters that we grab glucose from the urine and put it back in the bloodstream. And there's other things we can grab there. Say, hey, where our sodium's low, let's grab some sodium. Or our blood pressure is low, let's grab some sodium. Water follows, and our blood pressure gets fixed, right? So all those things get filtered through, and then it then gets peed out, right? But over time, your glomerulus gets damaged, and that damage lets more things through. And what are things that should not get filtered? What if there's some things that should not go into your urine? What should you not see in your urine? You should not see blood in your urine, and you should not see what? Protein, right? Glucose is after a certain point. And once those glucose transporters have absorbed as much as they can, then it's going to spill over into the urine. But you should not see protein, or you should not see blood that's in the urine. That means that the glomerulus, the filter, is broken. The holes are bigger than they should be. Okay, so blood comes in, right? Here's the afferent arriving, right? And then E is exiting, efferent. But all of that blood arrives, and then it gets dumped into the kidneys, right? Or dumped into the nephron, technically. How many nephrons are in a kidney? 1 million, right? 1 million nephrons are in each kidney. So those can die, and as they die over time, then the amount of filtration you can do per day or per minute reduces, right? And that's called the glomerular filtration rate, the GFR. All right, so the GFR is usually what we're looking at. We're determining if someone is, if the kidneys are getting worse or not. All right, so GFR right here, that's the classic way we're nowadays, last 10, 15 years, we're looking at how much protein is also spilled in the urine. Not only how much are the kidneys filtering, but how much protein is actually measured in the urine. And that protein is a little more objective because GFR is just calculated. You can't just stick a meat thermometer in someone's kidney. It's like, oh yeah, GFR, that's 100 mLs a minute. How would you know that, right? So it's a calculated method. So GFR is looking just calculated based on age, based on what their creatinine is, based on what their weight is, and that's going to estimate what someone's GFR is. So it's not exact, but if we compare that measurement to what's actually coming out in the urine, the protein in the urine, the albumin in the urine, then that's going to let us know that they have the kidney that's damaged, right? And we can measure that. We can say, well, shoot, your kidney might be reversible before stage 3, but after stage 3, your GFR starts going down, right? Your creatinine, BUN creatinine starts going up. Protein in the urine starts going up, right? The number of nephrons that are active start going down. So really stage 3 is the point of no return. You can't really bounce back from someone's kidney disease when they have stage 3, 4, 5. And stage 5 is what? That is end-stage renal disease, right? So sometimes people say, oh, they have CKD stage 5 / end-stage renal disease. That is end-stage renal disease. That means you need to be put on dialysis. Dialysis is a form of renal replacement therapy. It replaces your renals, and it's a therapy, right? So that's what you need at that point. It's an external kidney. We need to be able to do what the kidney does. And what does the kidney do? It filters stuff, right? It gets rid of stuff, right? And it also reabsorbs stuff. So things get lost in the urine, but really the problem with someone with CKD and end-stage renal disease is we're not getting rid of stuff. What stuff should we not want to get rid of? Which ones do we want to not build up, right? That our kidneys get rid of. Things just flow into the urine, and he's like, oh, goodbye, right? But what do we say? We say, but now we can't say goodbye to it. Now we have to make friends with it. What are some things that we would not want to build up because our kidneys are not working? Urea, right? Urea is a toxin, right? We get rid of urea, and that's our blood urea nitrogen, right? Our BUN is at a certain level, and we want to get rid of it, right? We don't want to have it around. So the BUN can build up and cause problems. What's something else you don't want to build up?
Creatinine.
Creatinine is fine. Creatinine is a waste product, but creatinine is actually a very, very good way to measure how good someone's kidneys are functioning, right? So usually normal creatinine is like 0.3, 0.4 to 1.4. And when it starts going 1.8, 2.2, 3.5, greater than 4, you can tell someone's kidneys are failing. But that doesn't really cause problems like BUN does. BUN is a toxin. Creatinine is a waste product, but it's not a toxin. It's not going to cause toxic damage. What's something else you don't want to build up? Acids, good. So just plain old hydrogen ions or acids, right? You can't get rid of acids anymore. You can't do that whole ABG thing where your kidneys are able to compensate, right? So you can't get rid of acids. Well, I can't get rid of bicarb too. Isn't it going to level out? Well, no, you're going to keep building up those acids, and you can get acidotic. Would that be respiratory acidosis or metabolic acidosis? It'd be a metabolic acidosis if you're building up acids. And then what else? Something else you don't want to build up? Potassium, right? You can't get rid of potassium. You only have one way to get rid of potassium in your body, and that is, or in your blood, for instance, is through the kidneys, right? But you have what hormone? Aldosterone, right? So if aldosterone could be being produced, and it's probably going to be produced, like it's kind of like trying to hit, like work, and it can't, right? Because the kidney nephrons are literally dying. They're literally shriveling up and dying. So over time, we're losing nephrons here. So those nephrons can't get rid of potassium, so your potassium level goes up. And what does that do to your ABG when your potassium level goes up? It gets acidosis. It's like which one came first? Well, you get acidosis, then you get hyperkalemia. Well, they're both going to happen at the same time. And then now you have someone get DKA. Well, shoot, that's an extra acid, right? We already have metabolic acidosis and kidney failure. We already have hyperkalemia. And then you start giving medications that might raise their potassium. That's going to be a problem. Okay, so 1 in 7 in the U.S. has this. About 10% of the world develops CKD. So it's pretty ubiquitous. You're going to see it a lot, right? The higher stage, that means the faster the development you're going to get to end-stage renal disease. So once you have stage 1, stage 2, it's a pretty slow process. You can maybe reverse it. But once you get to stage 3, you're going to get to stage 3B, 3AB really, really quick because there are 2 stages of 3. And then 4 is going to happen quick, and then 5 is going to happen quick. When you have stage 5, that means less than 15% of your nephrons, or not 15% of your, less than 15 mLs per minute technically, is being perfused or being filtered by your kidneys. But the amount of nephrons that are working are very, very, very small. Okay, so the albumin to creatinine ratio, that looks at how much albumin is getting lost in the urine. Should there be albumin in the urine? No, right? What other disease processes do we measure albumin in the urine for? Diabetes and? No, not liver disease. Hypertension, right? Diabetes and hypertension, we measure microalbumins, right? We do a UA and we say, oh, you have protein in your urine. Let's do another test and see how much microalbumin you have. How much albumin is leaking into the urine. That's a sign that your kidneys are damaged, right? And we compare how much albumin is leaving and what if the creatinine level starts going up. and that's going to tell you that they have kidney disease, or that's developing over time. All right, because there is such thing as acute injury, but this is like over time, like an outpatient, every 3 months, every 6 months, every year. The creatinine keeps going up. The albumin in the urine keeps going up. That means that their kidneys are damaged or damaging, right? That means they're not managing their diabetes or their hypertension or something else that's causing damage to the kidneys. Okay, so GFR was the OG. That's the one we used all the time. 130 mLs per minute or higher is a normal GFR, and then as that reduces over time, because that's amongst all your kidneys, 130 mLs per minute. So if that gets lower and lower and lower, that means your kidneys are not getting GFR, or glomerular filtration, right? So there's not a lot of glomerular filtration happening. So if our GFR gets lower and lower and lower, our kidneys are dying and dying and dying. So there's a little cute clock you can look at. So if you have a 12 o'clock, 9 o'clock, 6 o'clock, 3 o'clock, you can figure out what stage they're at. It correlates to the stage. So 120 to 90 is stage 1, right? 190 to 60 is stage 2. So you're just going backwards, going counterclockwise. Or if you're Australian or British, it's anti-clockwise. I can't do a British accent just yet. All right, so that's what GFR is looking at. It's how much is actually filtering through the kidney at any one time. And again, that is calculated, and it's also based on race. There's some question about whether that's ethical or not to calculate it based on race. But either way, it looks at creatinine, looks at your weight, looks at your sex, looks at your age, looks at your race, and says this is your GFR. This is what you are. Okay, this is what we calculated your kidney function to be, right? And it really was dependent on that creatinine too. If that creatinine starts going up and up and up, that tells you that your kidneys aren't working. And as we'll learn, creatinine is really the one you're going to look at in the hospital setting to see if someone's getting worse or better kidney function-wise. BUN can change day to day, and we'll talk about why that happens. But creatinine is not going to change day to day. What does creatinine come from? Where does that even happen? Well, you buy it from GMC, right? You buy it from the nutrition store. You buy creatinine. You better not be buying creatinine, because creatinine is the waste product of creatine that you bought at the nutrition store, right? So creatine is fuel, quick fuel for your muscles, right? And you break down that quick fuel into creatinine. So your muscles, with their waste product, right? The waste product of a muscle is creatinine. And going from day to day, is grandma going to go from 10 pounds or 50 pounds of muscle to 150 pounds of muscle? No, that's not going to happen. So that's kind of why creatinine is our go-to lab value to see if someone's kidney function is good or not. Okay, so GFR is the amount of blood going through the kidney, right? You got 1 million nephrons per kidney, and if your GFR starts falling and falling and falling, that means your nephrons are dying and dying and dying. Okay, so less flow means less functional nephrons, right? And you're going to start building up fluids and toxins, and that's including medications. So often medications have to be renally dosed, right? They have to be dosed for someone with kidney failure, or we have to reduce the dose just overall, or we just don't give them at all. What's a medication we don't give to someone with kidney failure? Smells like diabetes. Metformin. Don't give metformin to someone with chronic kidney disease. That's going to cause problems, right? So that's an example of someone you would not give. You would just not give the medication. Other medications, you could just renally dose them. Okay. So what else? So normal GFR, right? Normal glomerular filters everything, right? Everything goes in there except for blood and proteins. And then if we see proteins in the urine, that means our kidneys are breaking apart, right? Specifically our glomerulus. Our glomerulus was the gatekeeper for those things. It was the strainer for those things. Okay, and then once all that stuff does get into the urine there, once all that stuff gets into the nephron, into the tubules, right, the distal or proximal distal convoluted tubule, the loop of Henle, all that fun stuff, that we have all kinds of little protein transporters along there that can reabsorb things that we want to reabsorb, right? Like we want to reabsorb sodium, we want to reabsorb some, some glucose, right? We have other things we can reabsorb if we want to. Okay, so we can reabsorb nutrients like glucose and lights. But really, we're going to say goodbye and we're to other things that we wanted to get rid of, other waste products, such as what again? Such as urea, acids, right? And other electrolytes that we didn't want. So if our potassium level is too high, well, we're just going to get rid of it, right? And the kidney doesn't just decide that, oh, too much potassium. It does that based on the presence of aldosterone. Aldosterone measured the potassium in the serum, and then it got released, and then it said, well, let's go to the kidney and get rid of it, right? In exchange for sodium, of course. All right, so that's the idea behind staging of chronic kidney disease. It is a stage 1 through 5, and how you know someone's worse, kidney function is worse, what are you gonna look at? What labs? You can look at the creatinine, for sure. What else? The BUN will tell you someone's kidney might not be working, but it's not as accurate as the creatinine. What's something else you look at? GFR, and GFR is actually based on the creatinine. It uses creatinine in it, right, to figure out what someone's GFR is. And what's something else you look at to see if someone's kidney function is bad? Metabolic panel can tell you that they're getting complications, good, but what's something they can look in the office setting? They say, pee in this cup, and I'm going to tell you if your kidneys are good or not. Protein, right? You see protein in the urine, so it's the albumin to creatinine ratio. Creatinine's high, albumin's high, that's not good. Not albumin in the serum, but albumin in the urine. And what happens to your urine when you have too much protein in it? It's nasty. That's a good description. What else? It's not going to say nasty on the test. It's going to say cloudy. No, cloudy is a UTI, right? You shouldn't have a UTI either. Foamy, right? So it should not be foamy, right? Urine can be foamy. Sometimes there's some reasons like you have extra protein, you might get a foamy urine, but someone here has foamy urine because their kidneys are failing, right? And we'll talk about glomerulonephritis later at the end of CKD, and in that disease process, they're just spilling all kinds of albumin into their urine, and they're going to be very, very foamy. All right, so what are the causes of CKD? What's the patho of CKD? So the patho is that the glomerulus is breaking down, right? It's breaking down because we have diabetes, hypertension. Those are some of our most common reasons for kidney disease. But this glomerulus here, right? So here we have a normal glomerulus, and it leaves, and all that fluid just dumps into the nephron. And then what if that is broken down? Like in diabetes, it destroys the surrounding cells. Kind of like we have Schwann cells and oligodendrocytes, we have what are called podocytes that surround blood vessels, right? And those podocytes just break apart. And those podocytes were actually what were keeping everything together. Those are what's making the holes small like they were. And when they start breaking down, you're going to start getting a damaged nephron, specifically the glomerulus of the nephron. All right, and that damage is irreversible. It is slow, but and it can be fast if you get acute kidney injury. That can happen. They can escalate you to whatever stage you came out of the hospital with when you went to the hospital with acute kidney injury. But either way, you're going to end up with some kind of stage of CKD, and it's going to, it is slow. It's not going to be like, 3 months, bam, you're on dialysis, unless they found you in stage 4, stage 5 already. But usually it's going to be progressive. Okay, so it's irreversible damage, right? When you get 50% loss, if you look back at the previous slide, 50% loss was a stage 3, right? GFR less than 50. So you got inadequate blood flow could be the reason. You got inadequate blood flow over time, or I have direct damage to my kidney, like hypertension. What does hypertension do? It's doing donuts in the parking lot of the glomerulus. It's just tearing it apart, and that's going to eventually, that glomerulus to get scarred, and it's going to get damaged, and it's going to die off, right? And it's not just one little tiny nephron; it's through all 1 million nephrons at once, right? And they're gonna just give up on hypertension. Okay, and then when one nephron dies, like one guy just gives, I'm peace, I'm done. I'm not dealing with this anymore. It's too much pressure. All right, they're going to go ahead and they're going to die. Now that puts extra work on the other nephrons, and they're going to get all the brunt of the pressure. The pressure that was going to that one nephron is now going to the other ones. All right, and it's going to keep being progressive. Right, and then all of a sudden your kidneys are going to, sometimes they say, well, I'm not getting blood flow, right? Because the nephrons can get kind of scarred up over time. You're not getting blood flow into the kidney, and then the renin system gets activated. I was like, is that going to help? That's going to do what to my blood pressure? That's going to go up, right? The renin system is the renin-angiotensin-aldosterone system. That's going to fire up the SNS. It's going to fire up the vasoconstriction. It's going to fire up ADH to vasoconstrict and raise my blood pressure, and that's going to damage my kidneys even more, right? But what if we're talking about CHF? That's a low flow system, right? That's an inadequate blood flow over time. And CHF, your heart starts giving up starts giving up more, and the nephrons start dying off because you're not getting blood flow to your kidneys. Right? So CHF can be a reason for kidney failure, diabetes, hypertension, all the things we've been talking about, right? And then just straight up inflammation. We just have inflammation throughout our body. It's going to affect our vessels, but it's also going to affect our glomerulus, right? Our glomerulus is going to start dying off as well. It's not first or second place, but it's there. ASCVD and CHF are going to, and then, ASCVD always has a consequence to it, right? It's usually asymptomatic until it's not. What are some consequences of having ASCVD? You can have a stroke, right? You can have, that's not really affect the kidneys much, but you're going to have what? You got the hypertension, right? And then you got the decreased blood flow to the kidneys. Then you have more RAS system firing off. It's a whole downward spiral after that. It's just going to cause more damage to the kidneys, okay? So angiotensin 2 is part of the RAS system, and what does angiotensin 2 do? It raises preloads, right? That might help your blood pressure, but that blood pressure might even increase the damage to my kidneys, or that increased blood pressure, increased volume for my blood pressure might damage my heart more, right? And also this angiotensin 2 that gets released is going to do remodeling. And we know that remodeling in the body is never a good thing. That's a red flag. Oh, we're going to remodel you. It's like, no, go away. I don't need you to remodel. I'll try to figure it out myself. So remodeling is going to remodel the glomeruli, and it's not going to look anything like a glomerulus, and that's going to cause downward spiral. What's the disease process where we don't want remodeling to happen? CHF, right? And what medication do we give to prevent that CHF remodeling? We give ACE inhibitors and ARBs, right? That block angiotensin 2 and block its formation, right? So ironically, you're going to be giving these guys, you're going to also give ACE inhibitors and ARBs to CKD patients to prevent that remodeling. It's like, well, wait. There's a side effect that doesn't sound good for a CKD patient. What side effect is that of ACE inhibitors and ARBs? Hyperkalemia, but we deal with it, right? So because it's the risk versus benefits, right? And also we can give them stuff to get rid of potassium, right? We have the primary way to get rid of potassium in your serum is to pee it out, right? But what if you can't pee it out? What's another way to get rid of potassium?
Dialysis.
You could do dialysis, but we don't offer dialysis until stage 5 when your kidneys are absolutely dead. Well, they don't pee. You can't give diuretics, so what's the other option? What's part of the cocktail? What's that? Bicarbonate's going to work. Bicarbonate's just going to shuffle the potassium from the serum to the cells, and then they're going to go, "Whoa, what am I doing here?" It's going to switch back. No, aldosterone supplement's not going to. No, aldosterone, because aldosterone is going to go to the kidneys and make it get rid of potassium. The kidney's like, "I'm dead. We're closed for business." Huh? Insulin's going to just shuffle the potassium into the cell. Calcium's going to also shuffle in the cell to help the heart. What else is in the cocktail? Nephrostomy? No, that's for like a stone that's blocking your kidneys. What else? Huh? I thought I heard it. What's that? K-Xlate if it's 2014, but we have two other agents to poop it out. Right? We can poop out potassium. So where does potassium come from? From your diet, right? So let's say, well, as you eat, let's give you a medication that's going to inhibit the absorption of potassium, right? So K-Xlate, if you're in 2014, that can work 10 years ago. Otherwise, you can give 2 other agents that will bind the potassium in the gut, right? So it doesn't get absorbed. So we give the ACE inhibitor or the ARB, and we give them this medication that's going to lower their potassium. The brand name for that medication is called Lokelma, right? That's called sodium zirconium, right? Sodium zirconium or patiramir, those are the medications that will absorb the potassium in the gut, and then it will get pooped out, okay? Once it's already gone from the gut to the bloodstream, it's too late, right? So we got to fix it while it's in the gut. All right, so aside from the RAS being get released, we're going to have the SNS get fired off, and the SNS comes down here, the little nerve fibers there. The SNS is also going to release the RAS, so that's going to be a big problem. We're going to get a whole bunch of glomerular damage, and when the glomerulus gets damaged, what happens? What happens when your glomerulus gets damaged? It doesn't filter. So it means it actually just lets everything through. It's like doesn't get scarred off. It just lets everything through, and it lets through the RBCs and it lets through the proteins. All right. So the causes of CKD we can separate into vascular causes. All right, so we've got vascular causes here. You got infections over time, chronic infections can lead you to having CKD. Drugs can do it, right? If you're on NSAIDs for a long time, NSAIDs can cause your kidneys to die, right? NSAIDs are renal toxic or nephrotoxic, right? Someone has kidney disease, we should probably not be on NSAIDs, right? The reason being is what the whole purpose of the RAS system was to make sure that we got more flow to our kidneys, right? The RAS system, the angiotensin 2, went in there and it squeezed the hose right here. It squeezed it, so that any kind of inflowing blood went downward into the glomerulus, right? And then we have helpful prostaglandins, and these prostaglandins actually vasodilate and help our kidneys. What do NSAIDs do? They block the fiery prostaglandins that cause pain, but they also block the other good prostaglandins that actually perfused our kidney. So that's a problem. So chronic NSAID use is like causing chronic vasoconstriction to our kidneys, right? So that's a bad situation. Morphine is something you would not give if someone has kidney disease because it has a toxic metabolite that can cause seizures. That's not good. And then we have antibiotics that are nephrotoxic as well that we have to be concerned about. We might be able to renally dose it, right? And if they renally dose antibiotics, what do you check to make sure that it's good, that it's not getting toxic? Peak and troughs, very good. So like a vancomycin trough, they say, oh, the trough is this, go ahead and give the next dose. Or the trough is way too high, that means it's accumulating too much, it's going to cause side effects. Okay, so going back to vascular, right? So vascular, we've got diabetes, that's the most common. 50% of the time, diabetes is causing your kidneys to die. So how do we make sure someone's diabetes is under control? Make sure their A1C is less than 7%. If it's greater than 6.5, you have diabetes. But when someone has diabetes, you can make sure it's less than 7%, right? So make sure the diabetes is under control. Also, yearly, we're going to check what? For diabetes and hypertensive patients, we're checking what in the urine? The microalbumin levels, right? There is such thing as an albumin level of the serum that's liver stuff, or that's not anything to do with the kidneys, right? That tells you that the liver is making albumin when you check albumin levels. And also to make albumin, you have to have proteins, right? So they can tell you if you're malnourished too. Right? So we got glycosylation. That's the rock candy. We're rock candying the glomerulus, right? We're turning it into a big candy factory, right? And we're going to make it non-functional. Okay. And then hypertension, that's doing mechanical damage and causing scarring of the glomerulus, and that can cause our kidneys to die over time. And then when one nephron dies, it's going to put extra work on the other nephrons, and they're going to start getting inflamed, and they're going to start remodeling, and that's going to start leading to further damage and further reduction in our function. And how do we assess function of the kidneys? You look at creatinine and use that creatinine to calculate their GFR, right? And we can also look at their albumin to creatinine ratio. Okay, and then ASCVD, right? ASCVD is causing hypertension, but it's also causing coronary artery disease. It's also causing, that can lead to an MI, and that can lead to CHF. And when you have CHF, what happens? Is that good perfusion or bad perfusion to the kidneys? That's bad perfusion to the kidneys. So that's going to be, and then what the kidney's going to do, it's going to say, well, I need more perfusion. It's going to squeeze out some more renin. The whole RAS is going to fire off. The SNS is going to fire off. Vasopressor is going to fire off. And that's going to put a lot more work on the heart. But it's also going to not help the kidneys, because now the kidneys are going to get some hypertensive damage, ironically. Okay, so infectious, so we'll talk about glomerulonephritis, I think, as our last subject, and also pyelonephritis we'll talk about as our last subject as well, as significant causes of chronic kidney disease. All right, there are other things that can cause kidney disease. There's polycystic kidney disease, which is actually third place. We used to talk about that in Med-Surg and this class, but then I think it's moved to peds, all right, because it is a genetic thing that you deal with through all of your, really into adulthood as well, but it's something you struggle with as a kid and teen. And then lupus, we'll talk about that more next semester, but lupus is an important cause of glomerulonephritis as well. So those are, you have this autoimmune attack of your kidneys and an attack of your glomerulus. So your glomerulus gets attacked and inflamed and damaged, and it doesn't work good. Okay, so here we have CHF happening, right? And then we also have kidney disease happening, and kidney disease causes CHF because of all of those neurohormones that get released. We get all these risk factors here that might be causing the kidney disease, and a lot of those risk factors also cause CHF too, so they're all kind of interrelated. Okay, and you retain all the sodium and water, and all this sodium and water is going to put extra work on the heart, right? That's going to put extra, make your blood pressure higher, and that's going to put damage in your kidneys. So it's all interrelated, right? It's all going to cause damage, and your kidney disease is going to eventually end up with dialysis, which is renal replacement therapy. Okay, so there are a few varieties of renal replacement therapy. Hemodialysis is the most common in America. Okay, so here we have a worsening kidney function due to diabetes, hypertension, smoking, obesity. We know smoking and obesity put us at risk for what disease process? Hypertension, but also ASCVD and COPD. COPD puts you at risk for, you can't put you for right-sided CHF, but COPD is just a whole bunch of inflammation as well, right? And especially if it's due to smoking. And that inflammation, now it's going to be inflammation through all the vessels. Now we got ASCVD. ASCVD is hypertension. Hypertension is damage to the kidneys. So it's all going to be related. I mean, you can like roll the dice, and it's probably going to lead to chronic kidney disease or CHF or stroke, right? Those are the big things that we've been talking about. Okay, and then we have bad outcomes because of that, right? We might need to get beyond dialysis, right? And we get a lot of complications of our kidneys dying. So a lot of this, when you talk about CKD, and you talk about, you break it down in your normal table as like, what are the causes, what are the symptoms, what are the treatments, well, and what are the complications? Just like diabetes, there's a lot of complications, unfortunately, right, that we have to manage because the kidney has a pretty important function in the body. Okay, so what are the symptoms of CKD? Well, we got to think of what does the kidney do normally. So what does the kidney do normally? It gets rid of, it pees, right? Well, actually, that's your urethra that does the peeing job, and your bladder stores it. The kidneys micturate, right? They are forming urine, right? They aren't peeing urine, but they are forming urine, and they are making the best urine you ever had, right? They're making sure it gets rid of toxins. I guess it's not going to taste good if it has toxins in it, but they're making sure it gets rid of extra sugar. It's going to hold on to the sugar that you do want. It's going to hold on to electrolytes that you do want. It's going to get rid of electrolytes, right? So it's going to make urine, and that's important because those things can build up, right? So what are those things that we don't want to build up? So you don't want potassium to build up, so potassium can build up. So we got potassium excretion here. I thought I had it here, hyperkalemia, right? So one of your jobs, your kidneys, is to balance potassium, right? And then it also gets rid of what else? Urea, right? What does urea come from? It's a waste product, but what does it come from? Nitrogen. It's a nitrogenous waste product. What does it come from, though? Diet is a good answer. What in the diet? Sodium? No. Sodium. Potassium. Potassium. That's an electrolyte. Protein. Very good. So protein in your diet gets broken down into BUN by the liver, right? And that extra protein that you don't need, because you can eat like a Big Mac and you can eat drink a protein shake, but if you don't go work out at the gym, that did not do any good. It's like this guy, and it's going to go ahead and break it down, right? Excess protein, and excess protein is going to be formed into BUN, right? And you're going to pee that out. So you're going to pee out that blood urea nitrogen. So BUN though can break up, right? So that's why we break up. It can build up, right? So that's why one of the things we recommend for a CKD patient is a low protein diet for that reason. All right, there's a little controversy there, but we do still recommend a low protein diet for a kidney patient because the only way you get BUN is from protein, right? But you need protein to survive. So it's like, what's the right amount, right? So BUN builds up, right? So we get rid of BUN, elimination of nitrogenous wastes such as BUN. That builds up. That builds up and builds up and builds up. You could call that uremia, right? The urea and the emia, or urea and the blood. But we don't, we're kidney guys, they needed something else to latch onto. So what do you call it when your BUN's too high? Azotemia. Good. So azotemia is the same thing as uremia. That means you have too much nitrogenous waste, which is what azo means, or you have too much urea, which is what urea means, right? So you have uremia or azotemia. That's an elevated BUN in your bloodstream because you couldn't get rid of it, right? These guys are going to have elevated potassiums. They're going to have elevated creatinines as well. So creatinine will be high as well. Where do I have it at? Creatinine, right? So that's a problem. And but the creatinine, sorry, backtrack. The creatinine is not really a problem, but if it's going up, it's a problem. But it really doesn't cause problems like BUN does. BUN is what we call non-polar, means it can cross membranes back and forth. Whereas creatinine is polar. It hits a membrane, it bounces off. It's reflected, right? If it's trying to get into a tissue or into a organ system. But BUN has a multipass. Like, look, see, multipass. Let me in, coming in, right? So it crosses the blood-brain barrier. It crosses into the skin. It makes your skin itchy. It crosses into your blood-brain barrier, into your brain. It makes your brain not itchy, but altered, right? So it can go everywhere. It can go to your heart and go through your heart and into your pericardium and cause pericarditis. It can go into your bone marrow and damage your bone marrow and make you stop making RBCs, platelets, and white blood cells. It can go into the coag cascade and stop it so that you start bleeding more. So it's a problem when BUN starts building up. We have a slide dedicated to BUN. All right, so we got BUN, potassium. What else will you not be able to get rid of? This is just the filtration function of the kidneys. What else do we not filter or not get rid of? What's that? Acids. Very good. So you get what kind of acidosis? You get a metabolic acidosis, right? You get hyperkalemia and metabolic acidosis. I thought I had it here, but you got high potassium, right? And you got metabolic acidosis. Okay, and then what else? So your kidneys get rid of phosphorus and they get rid of calcium, right? So you pee out calcium and phosphorus. And we have hormones that will adjust that. Say, oh, get rid of more phosphorus than calcium, or get rid of more calcium than phosphorus. But those hormones don't matter anymore if your kidneys are dead, right? So if your kidneys are dead, you can't get rid of calcium or phosphorus. So which one's going to be high, or both going to be high? So one's high, one's low. So phosphorus gets high and the calcium gets low. So because when phosphorus rises, it's going to start binding, whenever it sees calcium nearby, it's like Romeo and Juliet. It's like star-crossed lovers. They're going to hook up, right? And they're going to crystallize as well. And they crystallize in the skin and make them pruritic. Right, what's pruritic mean? Itchy, right? So calcium and phosphorus can bind together and they can get itchy. So itchiness is a feature of someone who has chronic kidney disease because of the uremia and also because of the calcium phosphate issues. Okay, so the other reason we have calcium phosphate issues is because the other function of our kidney is to do what? Did I hear it? 1,25-dihydroxycalciferol? That's what I heard, right? So it makes vitamin D. It's the last step in making vitamin D, right? So you synthesize vitamin D in your skin from the sun, right? And then it goes to your kidney to get finalized so that you can actually make vitamin D and have vitamin D available to do its thing, right? What is vitamin D's thing? Immunity? No. Bones, a little bit. It's related to bones because you need what for bones? You need calcium and phosphorus for bones, right? So vitamin D's job is to go to the gut and absorb calcium and phosphorus, right? So now you can't absorb calcium and phosphorus to the gut, right? And whatever calcium and phosphorus you do have in your bloodstream does not get excreted, and then it gets bound together because phosphorus is a playa, right? So it's going to be those are the symptoms that you're going to get from vitamin D not working, right? And then the other job of the kidneys is to do what? So we've got vitamin D activation, phosphate elimination, acid-based stuff. What else? Erythropoietin. What is erythropoietin? It's the poietin of erythros, right? So poietin means the creation of, right? If you're like thrombopoietin, that's poietin of the thrombos, right? That's the liver does. But the kidney was tasked with this job, and it should have been the liver's job, but it's the kidney's job to do what? To make erythros, which is what? Erythrocytes are RBCs. So its job is to make erythropoietin, or EPO for short. It makes EPO, and that EPO then makes its way to the bone marrow, and in the bone marrow, it tells the bone marrow what to make, right? It says, what do you want, sir? And they say, I'm going to get some RBCs, please, right? And you make RBCs. What do you need to make RBCs besides erythropoietin? You need the building blocks of RBCs, which are iron, right, and folic acid, and B12 too. So when patients have anemia and chronic kidney disease, you're going to give them all these things. You're going to give them the erythropoietin, you're going to give them the iron, you're going to give them the folic acid, and you're going to give them the B12 so they can make RBCs as much as possible, because these guys are going to be polycythemic or anemic. They're going to be anemic. All right, so that means they're going to have low RBC counts, or low what else? What else in labs would be low? The hemoglobin and hematocrit. If the hemoglobin were 8, what would the hematocrit be? 24. Remember, it's a 1 to 3 relationship, right? So they have anemia. And what are symptoms of anemia? We have low oxygen levels. You're going to be fatigued because you don't have oxygen to your muscles. You don't have oxygen to your muscles and to your lungs. So you get what's DOE? That's dyspnea on exertion, right? So you get dyspneic on exertion. So you're walking, and you get short of breath. Oh, you got COPD. Sorry. Let's go. Stop smoking. All right, 16 to 18 hours per day, right? But no, it's like, I don't smoke. What are you talking about, right? Oh, you don't pee? Okay, that's all like urea, right? So you might have chronic kidney disease if you have dyspnea on exertion, right? There are other reasons for anemia, which we'll talk about next semester. We talk about other anemias out there like sickle cell and B12 deficiency, iron deficiency, et cetera. But this is a significant cause of anemia because your kidneys aren't making what? 125 no, it's not making erythropoietin, right? So you get anemic. And these guys are pallorous. What is pallorous? That's one of the 6 P's for neurovascular assessment. That's pale, right? So they are pale and white, okay? Or pale in color, okay? So hypertension, we mentioned why they're hypertensive. Why are you hypertensive? Why is their blood pressure elevated? Because that's what caused their kidney disease. But then you get the hypertension to their kidneys, and they already have hypertension, and the kidneys can't get rid of what? Fluid, right? And then now you have all this fluid buildup, and that's going to cause a rise in your blood pressure, right? So they're hypertensive, and they're also fluid overload too. So what are some symptoms of fluid overload? Hypertension, and what else? They can get what kind of edema? You get peripheral dependent edema. So it's whatever is dependent is going to get edematous, okay? All right, so that's kind of our intro to what's going to cause our complications, because each one of these are symptoms. They're hypertensive, they're not peeing, right? They could be anemic, right? They could be hyperkalemic. And how do you know someone's hyperkalemic? They're coming in and say, my EKG says what? Well, I have hyperkalemia. Peak T waves? So they've got a really astute patient. It's like, I got peaked T waves. Check me out. I got chest pain, shortness of breath, hypotension, confusion because my heart rate is low when I have hyperkalemia, right? So I have hyperkalemia, and I could be bradycardic as well, right? That's a danger. All right, so chemistry-wise, we can do labs. We can look to see what their basic metabolic panel reveals and what's going to be on the BMP. That shows your sodium, potassium, your BUN, creatinine, your anion gap, right? What are those going to look like? The GFR is also on there sometimes. That's just calculated based on your creatinine. And that GFR will be high or low. That's going to be low. That's a sign of the kidney's function, right? The kidney function is poor. It's going to be low. And then BUN and creatinine will both be elevated. Why is BUN elevated? Because they can't get rid of what? Urea, right? So we recommend what? A low protein diet, right? Because there's no medication known to man that can get rid of urea, right? You can't just hey, take this medication to get rid of your BUN. It doesn't happen, right? There's no medication known, okay? And then creatinine will go up, right? Because creatinine is also a waste product of what? Of creatine from the store, or creatine from that we make naturally in the muscles, right? So it's natural muscle breakdown. So day to day, if we're in the hospital, we can look at creatinine. That's the best thing that's going to tell you, because someone's muscle mass is not going to go from, it's like, whoa, grandma, what'd you do overnight, right? I know you were confused, you're doing sit-ups, but whoa, dang, right? It's like, you can look at those abs, right? So those are going to, they didn't gain all that muscle overnight, right? So that's from that's a continuous muscle breakdown, or continuous muscle waste product, I should say, is what makes creatinine, right? And then what about the calcium and phosphorus? What does that look like on the chemistry? You're going to have a low calcium and a high phosphorus, right? If you have a cute way to figure that out, I don't know, CKD, renal failure, RF, I don't know. You got to think of how that's related to, or CKD, vitamin D. I don't know. You can test vitamin D levels too. Those will be low. And then what about H and H? That's also going to be low because the EPO is low. We can do a urinalysis. The UA can measure what's something we look at to see if their CKD is flaring up or it has flared, because it doesn't flare up. It's a progression. You can look at the microalbumin. See if the microalbumin is there. Right? I didn't add it there. Let's put add albumin. Okay. So your microalbumin will be elevated. That's what we measure routinely. We measure microalbumin how often? Usually for diabetes and hypertensive patients, we measure how often? Q1 year at least. Okay. We can do it more often if we want to check. Oh, it is right there. Shoot. All right. Microalbumin Q1 year. And then what else can you measure on urine? You can measure if they have a UTI or pyelonephritis, because pyelonephritis was a cause of CKD, right? So we can look at that and look at these specific things on the UA, and we'll talk about that more with pyelonephritis. We talk about it a little later. But pyelo is, well, when you have a bacterial infection, one of those two is going to be positive, right? That tells you have a bacterial infection. Also, we can do a renal ultrasound. That's another diagnostic test we can do. We can do a renal ultrasound of their renals, of their kidneys, and we can see what the kidneys look like. So if someone has normal kidneys, have normal kidneys. So if someone has chronic kidney disease, you say, oh, they're super inflamed, they're going to be super big. But actually, they are shriveled up like a raisin. They're so shriveled, right? And they worked at that for 5 to 10 years. Look at my kidneys. They're so shriveled. They got raisin kidneys, right? Those are going to be because they cause damage, and the nephrons, every 1 million per kidney, start dying, and they start shriveling up, right? So this is a CKD kidney, right? On ultrasound, they can have small kidneys. When we look at PKD, like polycystic kidney disease, their kidneys can be huge. They get up to 2 to 3 liters of volume. It's a ridiculous amount. Okay. Also, when you have a stone, like a chronic stones, that could cause your kidneys to get big. Right? They get full of fluid. What's that called when your kidneys are full of fluid? Hydronephrosis. So that's something to look at to see if that can also be a result of a bacterial infection. Okay. So hydronephrosis. Okay, I don't know why that's there. Anyways, so also we can look at glucose is spilling in the urine. If glucose is spilling in the urine, that could tell you what might be brewing. Diabetes. They might have diabetes. It's like, do you have diabetes? It's like, no. It's like, let me check your A1C. And what's the A1C going to be if they have diabetes? Greater than 6.5, right? So greater than 6.5 is diabetes. Okay. So that's the diagnostic test and symptoms. The symptoms can overlap with the complications, but we're going to try to cluster the complications by themselves.